Good morning, everyone. Thank you for joining us. We have our third session today, and we have Dr. Gregory Ward here with us, who is going to present to us on cannabis and the endocannabinoid system. So, Dr. Ward, take it away.
Good morning. Good morning. How's everyone?
We are doing well.
Essentially, first of all, I want to thank Marlon for pulling this together. This is probably my third or second time. I'm sorry. It sounds like my video is, can everybody hear me?
Yes, we can hear you. Can you hear me?
Because I can't hear on the other side. Okay, you can hear me?
Yes, I can hear you. Is there?
I can hear you, but it's coming in and out. It's going in and out.
It may be your internet connection.
Okay. Well, I'm just going to go ahead. I'm sorry.
No, you can go ahead. We're recording, so we'll be able to.
Having some technical difficulties hearing you.
Yeah, you're frozen.
Okay.
Yeah.
Okay. All right. Well, once again, thank you again for the invitation. Today, we're going to discuss medical cannabis and clinical practice. And one of the things with respect to cannabis and educating and even learning about cannabis is that as an endocannabinoidologist, and I'm gonna pay homage to the term endocannabinoidology to the Knox group, the doctors Knox of 3 and 4. They're high-powered ladies who have explored cannabis. You'll hear from one of the Dr. Knox in this session. But as an endocannabinoidologist, our role is to educate and also learn about the endocannabinoid system. By way of my clinical practice, I am a physical medicine specialist. In fact, I was just running here to give this lecture from the hospital, but I specialize in physical medicine rehabilitation. And over the course of the last 3 years, I've been practicing medical cannabis in the state of Louisiana for the last year and a half, and then in Florida 2 to 3 years prior, starting in 2016. In that clinical practice is where I learned a lot about the endocannabinoid system, and I've had opportunity to share my clinical expertise and experience in this arena over the last few years or so. So entitled is Medical Cannabis and Clinical Practice, but also entitled in this is my clinical experience over the last 2 to 3 years and what 5,000 patients have taught me. In reference to this, we're going to discuss the endocannabinoid system in its entirety. However, we understand that many patients that span over the course of medicine, I've got pretty much 5,000 patients over the last 3 to 2 years. I'm going to say more 3 years, ages 3 with autism spectrum disorder, and the age of 97 is a patient who had Parkinson's disease. For whom medical cannabis was recommended, and as a result, favorable outcomes were rendered. Most common causes anxiety and a 1 in a million disease. And as a result of that, in every aspect of medicine, the senators, the DA agents, the professionals, the athletes, hospital administrators, physicians, nurses, the unemployed, the disabled, and also the Social Security are all involved and are part of my treatment crew, and also part of my treatment and my patients. So, but before I started cannabis, there's behind cannabis, and I think this is very interesting to follow. Over a 10,000 year, there's an archaeological site in Taiwan that contains pottery fragments, and in that group, some believe that a lot of the rope that was made from hemp, the fibers from the cannabis plant. And as the wet clay, and that was used, of course, into Springer, who established this in 1980, cannabis was probably evolved during the first 12,000 years of mankind. In 2008, in a tomb in the Gobi Desert was unearthed and revealed a body that, much like a shaman, was detailed, and this was dated back in 2700 BC. Now, you can imagine that if anyone in today's society had 2 pounds of cannabis, they would probably look like that skeleton while resting in jail. So you can see how things have changed with respect to how we're viewing cannabis, and the history behind it far exceeds where we are historically in today's date. In the United States, the cannabis history is as follows. In 1619, the first law in Jamestown required all settlers to grow hemp. In the mid-1800s, it was brought in through Mexico. In the early 1900s, the widespread medicinal use. Also, interestingly enough, in the early 1900s, Squibb, Bristol-Myers, and Bayer Aspirin were also the largest producers of heroin in the United States at that time. During that time, there was also the excessive use of opium. Cocaine was utilized in the medicinal community. People became involved using cocaine. They became addicted to cocaine. However, Bristol-Myers, Squibb, and Bayer decided that we would produce heroin in order to wean patients off of, or to help patients with cocaine addiction. So it's interesting to see how, historically speaking, how this has arrived. In 1937, the Marijuana Act was about $1 per ounce, allowed for $1 per ounce for tax purposes. In 1914, it was removed from the USP, United States Postal Service. And then in 1970, Controlled Substance Act deemed cannabis as a Schedule I narcotic and cocaine as a Schedule II. In 1996, California voters passed a Proposition 215, allowing the sale and medical use of marijuana for patients with AIDS, cancer, and other serious diseases. By law, U.S. state laws by state, the laws by state. Currently, these have changed somewhat. In Louisiana, we're now utilizing medical cannabis, but you can see that in some areas that there's medical marijuana use. Some states allow legality, no jail time possession for small amounts. In the red states, medical marijuana, there's no jail time for possession in small amounts. And in the blue states, medical and recreational cannabis is being legalized. And this is changing at this time. And this is data as of April 2019. So you can see 35 states and Washington, D.C. allow some use of cannabis over this period of time. The keys to success in understanding cannabis as a medicine is understanding biochemistry, the pharmacokinetics, dosing, strain information, the types of strain, it was sativa, indica, hybrid, or other. Dispensary, the products in the dispensary, and understanding the knowledge of those products in the dispensary. Certainly understanding the patient, the pathophysiology of different diseases and how it manifests, and more importantly, understanding how cannabis impacts disease and how it helps to treat and promote disease and help with disease management. And along with that, experience, goals of therapy, cannabis tolerance, and then finally directing the patients. In our clinical practice, we never let a patient leave without specific suggestions, specific medications, and dispensaries are also really valuable in that they help to keep the physicians updated as what types of products are utilized. And in understanding this, I usually go for this with my patients. First of all, talk a lot about what is cannabis, what are the main components of cannabis, and we'll talk about that as well. As a result, cannabinoids. Basically, cannabinoids are diverse chemical compounds that act on the cannabinoid receptors in cells, which is also an inhibitory neurotransmitter release. You have phytocannabinoids, you have endocannabinoids, and the synthetic cannabinoids. And there are typically 500 compounds found in the cannabis plant, and at least 130 of them have been identified as cannabinoids. When we look at this is a close-up of, if you look at the plant itself, this is an interesting close-up of the glandular process of the plant, which looks like dew on a plant, but it's actually, these are trichomes on the leaves of the cannabis plant. And the trichomes protect the plant, but they also secrete, it's almost like a thin layer of wax coating over the plant. But they also secrete numerous compounds, including cannabinoids, such as THC. So it's a very active plant, and phytocannabinoids are described as THC, which is a phytocannabinoid, and that's one of the main ingredients, and it's the more hypnotic component of the cannabis plant. There are basically two types. You want to look at the medical component of the plant, which is predominantly CBD and its derivatives, and there are many derivatives, and then THC is the more hypnotic aspect of the plant. With respect to the endocannabinoid system, this is an endogenous group of cannabinoid neurochromes and the receptor sites. There are central and also peripheral nervous system involvement with respect to the endocannabinoid system, and it also includes the immune system. The ligands, in other words, what are the main components or the main chemicals involved with, or the main neurotransmitters or chemicals involved in the endocannabinoid system? We have adenamine, which bind, there are two types of receptors, first of all, the CB1 receptors in the central nervous system, and there's CB2 receptors in the periphery. So in other words, there's CB2 receptors on the cardiovascular system, the pulmonary system, the GI system, the renal system, and also in the musculoskeletal system as well. As a second ligand, 2-arachidonoglycerol, which is called 2-AG, it predominantly binds the CB receptors type 1, found mainly in the central nervous system. It's also found in maternal, human, and bovine milk through maternal use of excretion of milk. And it's also a fatty acid amide hydrolase, which breaks down to 2-AG and acetaminophen. So in other words, the 2-AG, just parenthetically phrasing it, has medicinal properties located within the scopolamines themselves. There are amines, and interestingly enough, there's also the other analgesic that's part of the breakdown, acetaminophen. So already you're starting to see some of the chemical properties of these ligands that also are chemical properties of some of the medications that we take currently that are on the market. Acetaminophen for pain reduction. So already there's that component of the medicinal side from a chemical standpoint of its medicinal purpose and the medicinal use of cannabis. Finally, there's palmityl ethanolamide, which is also a proliferator of the alpha receptor cells in the nervous and central systems and also periphery. There's also G protein receptor, and there's also, and the G protein receptor is a binding site for these chemicals. In other words, you have to have a binding site in order to activate the endocannabinoid system. And in a nutshell, these are the three types of ligands that bind to the endocannabinoid system to help it activate within the human system or within the human body as an anti-inflammatory or anti-nociceptive, meaning helps to control pain, is also neuroprotective, and also anticonvulsant properties are located within these ligands as well as part of the cannabis plant, which is part of how it operates within, and these ligands help the cannabis, the components of cannabis operate within the endocannabinoid system, which is inherent in every mammalian structure. However, as a result of, in other words, we all have the endocannabinoid system. However, we do not produce in our bodies THC, nor do we produce CBD, but it's interesting to know that we have an endemic or an endogenous source of how the cannabis medicine operates within our body just naturally. The receptor sites, CB1, are found mostly in the brain, in both male and female reproductive systems, and is responsible for the euphoric and also the anticonvulsant effects of cannabis. CB2 receptors found in the immune system, also found in the spleen, also found in microglial cells in the human cerebellum, and is also responsible for the anti-inflammatory and also the peripheral responses in our body. One thing about, let me backtrack a little bit to kind of give you an intuitive example of CB2. For example, microglial cells in the human cerebellum. CBD, actually the microglial cells, let's say for example, in a patient who has dementia, we know that tau proteins and other byproducts of the cell structures that are produced in the central nervous system, such as tau proteins and neurofibrillary tangles, are pathologic components of what causes Alzheimer's, and in some respects also pathologic in patients with Parkinson's disease. With respect to CB2 receptors, when CBD binds to the receptor sites, it also helps the microglial cells clean up the nervous system. So the microglial cells in and of themselves, they are responsible for, they act like vacuum cleaners in the nervous system. They help the neural processes regulate properly by removing the debris, such as tau protein and neurofibrillary tangles. CBD attaches to the microglial cells and make them much more efficient in their cleaning efforts. As a result, you see improvement in the neuronal processes that take place in the brain. And as a result, a better outcome and function with respect to memory or mobility, depending on the type of condition. For example, we would expect as a result, improved memory, cognition in a patient with Alzheimer's dementia. And in the case of Parkinsonian patients where there's significant deficits in movement disorder, improvement in motion and how they move along in that regard, in combination with or as an adjunct agent with the other anti-Parkinsonian medications. So I just wanted to digress a little bit to kind of give an intuitive example of what this looks like and how we use it from a medical standpoint within the scope of our system and using the endocannabinoid system as an adjunct to all of our other systems in the body. CB1 receptors, they're presynaptic. In other words, there are two types of presynaptic and postsynaptic involvement. There's a G protein receptor. And when we talk about modulating sites, we mean how the molecule rotates on itself and how it attaches to certain receptor sites in the brain or in the central nervous system. CB1 receptors release glutamate and GABA. Glutamate is excitatory and GABA is inhibitory. However, glutamate also causes an inhibition of excitatory neurons. So in other words, it helps to produce the neuronal transmission to reduce pain. GABA helps to also inhibit pain. So as a stimulator, glutamate stimulates GABA, which is inhibitory, and the inhibitory aspects of the nerve transmitter GABA helps to reduce pain. So it requires glutamate to stimulate, which is a stimulator of an inhibitory system, which inhibits pain. It's kind of that cascade. When we talk about it inhibits release of glutamate and GABA, helps reduce pain throughout. With respect in the spinal cord, there are interneurons of dorsal horn, which is where pain transmission occurs, and also helps to stimulate and inhibits pain stimulation or release of pain stimulators from the nervous system and the central nervous system. There's also the expression of receptor sites of the neurotransmission release, and it also helps prevent, and this is what happens in seizure activity where there's excessive neuronal activity, and also in pain where there's excessive inflammatory activity. CB1 receptors help to reduce the amount of pain inflammation that takes place from a central nervous system standpoint, and also helps reduce neuronal activity that may impact a patient who may have a seizure disorder or some type of autism spectrum disorder that may be caused by some excitatory response in the central nervous system. CB1 also facilitates ghrelin, which is a hormone produced in the stomach that stimulates the secretion of growth hormone from the pituitary gland and also increases appetite. This is where the appetite increase takes place from ghrelin, and in the meantime, it also helps decrease GI activity. So in as much as you have an increase in appetite, in some cases where you're using cannabinoids, it doesn't necessarily mean that you're going to gain weight. It might feel like that, but it's not necessarily the case in many instances. So a lot of people get the munchies, quote unquote, as a result of this effect. CB2 receptors. They're in the peripheral they're in the peripheral tissues of the immune system. They release cytokine release, in other words, inflammatory release found in the monocytes. And these are components in the blood that help us fight inflammation, help us reduce pain, helps us to eliminate cancer cells and its deleterious effects on the immune system. And also it suppresses T cell receptor signal. In other words, it helps, can be also deleterious in helping control pain symptoms and inflammatory symptoms and other symptoms that cause disease and painful states and inflammation. It also assists with the modulation of intestinal inflammatory response as a result of reducing gut motility. And as a result, CB2 receptors and the use of cannabis is effective in patients who have Crohn's disease, can also be effective in patients with GERD. In some cases, I've seen it very effective in ulcerative colitis and other GI-based inflammatory processes as well. And then finally, the analgesic effects of the peripheral nervous system. CB2 receptors help to mediate the analgesic and pain benefits from cannabis with the use of its CB2 receptors as well. The CBD receptors, when it inherits or when it works with serotonin, helps to activate serotonin release. It helps to reduce pain perception. It helps to reduce inflammatory activity. It helps to control temperature and body temperature when it combines with vanilloid receptors as well, with respect to GRP55, which is an organ receptor antagonist in the cerebellum. It helps to promote blood pressure management, helps with bone density, and in some cases, it helps prevent osteoporosis. In addition to that, it also helps with respect to osteoporosis by way of inhibiting isochlastic function, which means osteoclasts are products that pretty much inhibit bone growth or may weaken bone, henceforth osteopenia. It causes the main cause of osteopenia, or it might be the main cause of promoting osteoporosis. So as you can see, CBD receptors help prevent or reduce the effects of osteoclast activity. CBD can also inhibit cancer proliferation by interfering with the T cell receptor sites, or what we call normal function or killer cells or normal killer cell function, enhancing, again, proliferation against cancer cells. And CBD is very interesting because it can actually detect cancer cells when our normal immune systems cannot. We don't quite understand the full mechanism behind it, but it has a propensity to help the immune system recognize cancer cells, which, interestingly enough, arrives from normal cells in our body. And the intuitive perspective from this is that CBD is actually the extra spy that helps the body detect the criminal, so to speak. So when we talk about the other anti-proliferative effects of tumor progression or regression, it helps to regress tumor. It helps to reduce amyloid plaques in the brain, which causes, again, neurological dysfunction in patients with Parkinson's or patients who have dementia or patients with other types of dementia, such as Pick's dementia and other types of dementia. So it helps to help the endocannabinoid system, helps the nervous system regulate and clean itself, and help to combat against further neurological digression. And moving forward with that, the negative, in other words, when we talk about allosteric effects, that's just the way that the molecule manipulates itself on the receptor sites. And as a result, this is how in the endocannabinoid system, it has the propensity to help control the levels of THC. So in other words, intuitively speaking, the endocannabinoid system knows when the body has had quite a bit of or enough of THC. And as a result, the CBD receptors can actually displace the THC from the receptor sites in the endocannabinoid system. Therefore, you displace the THC, therefore it inhibits patients from getting too overdose, or in other words, too much high, quote unquote, and also too much hallucinosis, or too many, in cases where there's a patient may have bipolar disorder, it helps to displace the THC so that it does not cause psychosis. Psychosis, number one cause of patients who are bipolar and they use this substance is because of the THC. And so CBD actually is an inhibitory feedback to allow displacement from the receptor sites of the THC molecule from the endocannabinoid system or from this immune or from the central nervous system to avoid the deleterious effects of what happens when you have a THC toxicity. Because the endocannabinoid system there are no receptor sites in the breathing mechanisms in the brainstem, which allow for cardiovascular function and respiratory function. And as a result, there's no suppression of these systems. And therefore, as a result, patients don't typically die from overdoses. Opioid system, there are receptors in the brainstem that suppress breathing and also suppress the cardiac activity. And therefore, as a result, patients die from overdoses of opioids as opposed to cannabis. And that's why you don't see the overdose, you don't see many overdoses or hardly any, if none, in the endocannabinoid system in the use of cannabis. And this is just an example of that displacement I was referring to. In the first aspect, we're looking at how CBD combines with the cannabinoid system or the endocannabinoid system, how it has a direct interaction with the opioid system, and to my right, how it has a direct interaction with the dopamine system that helps reduce addiction and depression. And in the serotonin system, it also helps direct and stimulate serotonin, which again helps reduce anxiety, addiction, and helps to reduce depression. And this is how that mechanism takes place in this particular sequence. Now, in this particular slide, this is merely just an illustration of all the different factors of the cannabis plant, predominating the medical component of it is the CBD and all its derivatives. And then there's also the THC derivatives, which you'll see isolated here. This is predominantly CBDV, CBD. You have CBG, which is also part of the CBD component, CBC, which is also part of the CBD regime. But here you also see the hypnotic components of cascade of this is predominantly CBD, and that's the more medical component of the cannabis system. So having an understanding, or at least some glimpse of an understanding of how it works, what evidence is there that is safe and we can apply it clinically? At this time, we're looking at, here's some data that's really interesting here. When you look at the number of deaths by FDA-approved drugs compared to cannabis, you can see cannabis, there are really no primary suspected deaths associated with cannabis. However, in the most recent data that I researched, there are some secondary deaths or secondary concerns with cannabis that may have contributed to deaths, but no primary deaths associated with cannabis. So you can see the total deaths are reported with any cannabis-related event or marijuana-related event is only 279. With medications that we use to treat for vomiting or antiemetics, you see there's 625 reported deaths associated with that. With antispasmodics, there might be a little bit lower rate with the use of antispasmodics overall, but again, these are FDA-approved drugs, okay? So my point with this is that, number one, antispasmodics might be lower in class with respect to reported deaths, but again, there are no deaths reported primarily from cannabis, but there are about 18, but there are reported deaths using antispasmodics. There are reported deaths using medications to treat psychosis. There are reported deaths direct related to these medications, which are all FDA approved. Other meds like ADD medication, depression, narcolepsy, erectile dysfunction, there are 8,100 reported deaths. And in the sum total of deaths caused by cannabis, you have, or related cannabis deaths, there's only 279 compared to 11,687 deaths associated with FDA-approved drugs, or at least from the 17 FDA-approved drugs that I've listed. The laws with respect to cannabis and the overdose mortality in the United States, you can read this, is 1999 and 2010. Medical cannabis laws are associated with significantly lower state-level opioid overdose mortality rates. Further investigation is required to determine how medical cannabis laws can interact with policies aimed at preventing opioid analgesic overdose. Now, this is a dilemma, I think, in the legal community. That's why lectures and seminars like this is very important to understand the science, so you can legislate, understanding what are the true aspects of cannabis, how do they work, and how you can legislate them appropriately, understanding how cannabis really works with respect to these concerns that are expressed about mortality and assisting these laws in their promulgation of such. With respect to chronic pain, this is one of the largest studies that was done. We know that in chronic pain management, there's no significant effects associated with cannabis with respect to chronic pain. It's the largest, in other words, this is the bottom line. There's no harm or cognitive deficits with the use of cannabis in chronic pain. In fact, in my population, patients who have chronic pain, I'm seeing, who've been on chronic opioids, I'm saying 70% of them actually wean off of opioids when I'm using cannabis products. Levels of pain, symptom distress, mood, and quality of life when using cannabis as an adjunct with for patients who have chronic pain dysfunction. Cannabis, overall in the medicinal arena, there's significant quality to support the evidence of use of chronic pain management, cannabis and chronic pain, improvements with nausea, improvements with vomiting related to chemotherapy, helps with weight gain in HIV population, helps with sleep disorders, and in other words, very effective in an overall analysis of all the possibilities for which cannabis can be used in the medical arena. shows that cannabis use in the medical arena is very effective overall. Now, what we're looking here is that the role of the cannabis, the role of the endocannabinoid system in pain management. This is just an illustration of what happens. Again, we talked about presynaptic GABA, which is inhibitory and also reduces pain. We see that in this way, this pre-GABA, this is a presynaptic, postsynaptic, and in a nutshell, we're finding that the CB1 receptors helps to suppress inflammatory release of mast cells, which causes further inflammation. The CB2 receptors help to mediate opioid receptors in primary afferent pathway. In other words, helps to modulate pain, helps to control pain, and helps reduce pain response and inflammation, and also neuropathic pain. And this is just an illustration of that, just from a biochemical standpoint. And this is the narrative there is just exactly what this shows. In ischemic perfusion, we know that CBD also helps increase brain perfusion by way of activating process that includes metabolic activity in the brain to allow for brain perfusion. And it also results in reducing the scavenging of all the byproducts or oxidative byproducts in the brain that prevent the brain from having better perfusion. And this is just an illustration, just in brief, of what this means. So in other words, it helps to increase brain flow or blood flow in the central nervous system, and helps prevent inflammatory process that takes place there as a result of stroke, and also other brain insults such as brain injury as well, or hemorrhagic bleeds as well. In heart disease, we know that it helps to suppress ischemia. We know that there's tissue pairing in the coronary artery in chronic pain, and it helps to increase perfusion of the blood of flow in the heart vessels. CBD attenuates oxidative stress, fibrosis, inflammation, cell death, and helps. In other words, it helps to heal brain tissue in cardiovascular disease, particularly if there's been a myocardial infarction, and is also very protective against doxorubicin-induced cardiomyopathy. Doxorubicin is a chemotherapy drug, and the number one side effect from doxorubicin is cardiac disease or cardiomyopathies. And in combination with CBD, this helps protect the effects of doxorubicin. CBD helps to protect muscle tissue or muscle injury associated with doxorubicin, and some other drugs that might be also cardiotoxic in the arena of treating cancer, and also in the arena of treating heart disease. That's just another illustration of it. In this particular instance, we know because CBD helps to stimulate calcium channel blockade. It helps to regulate heart arrhythmias like calcium channel blockers. So there are receptor sites with respect to CBD type 2 in the myocardium that helps the onset of controlling arrhythmias caused by cardiac disease as a result of electrolyte imbalances between sodium, potassium, and calcium. And in the cardiac disease, we know that CBD also acts just like a calcium channel blocker that's commonly used, like verapamil, some of the other calcium channel blockers that we treat for hypertension. And as a result, and because of that, CBD is also very effective in controlling blood pressure, as it is in helping prevent the heart from further ischemia, increasing blood perfusion, and also helping calcium channel blockade to promote better heart rhythm and maintaining heart homeostasis. And again, hypertension by the same mechanism. The endocannabinoid receptors, again, calcium channel blockade, assistance with blood perfusion, helps reduce blood pressure and minimize the effects of hypertension as well. That slide is not coming for me. But in cancer, we know that CBD type 2 and type 1 receptors helps to promote natural killer cells in the T cell structure. In other words, just in a nutshell, it helps to trigger and figure out which cancer cell types are abnormal, and as a result of a process to eradicate cancer and kill the cell. Just simple as that. It has, let me see if I can get this to. I'm seeing there's a little. Sorry about this. Well, I'm just going to comment on this. As an antipsychotic agent and as an anxiolytic agent, because CB receptors type 1 and 2 help to stimulate GABA, and that also helps reduce, it also stimulates GABAergic agents to help reduce anxiety, much like Valium. The medication Valium is an anxiolytic, is also GABAergic, which means it helps promote homeostasis. It also helps promote reduction in excitatory activity that causes or enhances psychosis or anxiety. And as a result, the anxiety is as a result of it stimulating in the amygdala of the brain, CB2 receptors in the amygdala of the brain, and CB1 receptors are in the brain, which stimulates anxiety. And as a result, real simply put, cannabis helps reduce anxiety disorders as a result of helping control the neuronal receptors and also the neural cascades that cause anxiety in the brain. And unfortunately, I can't get that slide to move forward. Now, when I look at the types of delivery for cannabis, let's kind of move forward since my slide's not working. These are the different types of cannabis with how we move forward with offering the patients. In other words, we have cannabis by way of vaporizing, we have topicals, we have lotions and creams, we have tinctures, oils, we have distillates, which are high concentrated oils, we have edibles, we have transdermal patches, and we also have suppositories. And by way of routes of administration, by inhalant form, using inhalants the quickest onset, usually about within 5 to 10 minutes. By the oral route, it's going to take about an hour. By the oral mucosal route, these are going to be tinctures. It's going to take about 15 to 45 minutes. And by topical, the onset of action is going to be variable. The pros of inhalants, that is rapid onset of action. Orally is going to be not odorous. In other words, oral route is going to be safer for patients who can't tolerate vaping. Vaping can sometimes irritate the lungs. Orals do not. However, the oral administration takes a longer time to metabolize because when you're using cannabis in the oral route as an edible, when it metabolizes, it also goes through a process in the liver whereby the delta-9 THC, which is the active component of the cannabis plant, the THC active component, converts in the liver to a more potent form of THC, a delta-11 THC. Having said that, those are typically the patients who wind up in the emergency room because they're really become ill and become sick. As a result of that, here's how it happens. Typically, we're used to using cannabis and as a rapid onset of action. The patients who are experiencing edibles for the first time may not get that same experience that they're getting from other routes of administration. So they say, well, I'll take one edible, they'll wait a little while, they'll take another. And by the time that they take the first edible, maybe 45 minutes has lapsed, the medication is starting to metabolize, the liver starting to metabolize the THC to a more potent form. Unfortunately, before that time happens, they're taking the second one because they don't feel the same results that they typically get by other routes of administration, which is much more quicker than they would with an edible. So they make the mistake, they take it, it's not even a mistake, they don't realize that this is what's happening. So you take the second oral dose, by that time, the first one is already metabolized to a more potent THC form. So you can imagine they've taken the second dose, so that's when toxicity takes place. Because the liver converts it to a much more toxic form and it's longer acting, and these are typically seen in the patients who have been using cannabis for a number of years. They've had other experience other types of cannabis, and they get to the oral form and they assume it's going to metabolize the same way, and this is what causes the problems. My advice in cases like this is when you take an oral form of a cannabis, cut it up, take one piece at a time, and dose it maybe an hour after you take, or 30 minutes after you take one dose of it, move to the next. But that's just an aside as the routes of administration and what happens when using in this regard. And we'll talk more about that in the next slide. Looking at what happens when you vaporize versus smoking. Smoking releases a lot of carcinogens. Vaping systems of cannabis produces little, if any, carbon dioxide. Vaping is more efficient, it's cost saving, and it's much safer. So far, when we're using vaping systems, we know that the vaping system of cannabis has two properties compared to tobacco. Tobacco, first of all, when it's inhaled in a smoke form of any kind, it has a tendency to irritate the lung tissue. It irritates the lung tissue by actually destroying the DNA properties that help lung tissue regenerate. The opposite of that is in the cannabis. With cannabis, CBD actually helps the reparative properties caused by THC irritation. So in other words, THC, when you're inhaling THC, it's the main ingredient that causes the cough, the irritation to the lung, and it does cause damage to the tissue nonetheless. But fortunately, CBD is reparative. So with respect to outcome, you don't see the same outcomes with respect to permanent damage to lung tissue with cannabis as you would with tobacco. By and large, with respect to one cigarette of cannabis typically holds on about, it's about 4 milligrams of THC to 5 milligrams of THC, but there's no evidence of any type. There's tar with it, but not as much as you see with tobacco. So in a cannabis cigar, you will see tar, which is almost 4 times that of a nicotine cigarette. However, the cannabis, the CBD aspects of that are reparative. So even though there's much more tar in the utilized in the cigarette of cannabis, CBD helps to repair the deleterious effects of tar. When we talk about bioavailability with metabolites, ingested is about 40%. When we look at this particular slide, what I want to illustrate here is that there's a 40% there's 40% of CBD is metabolized in the body when it's inhaled. And it's the same percentage that's inhaled or metabolized in the body when it's also THC based. So in other words, both CBD and THC when it's inhaled is about 40% absorbed in the body. When it's ingested, depending on the type, in other words, CBD when it's ingested is going to be metabolized in the liver, but you're only going to get, when it's ingested when you intake CBD, in other words, you're only going to get 10% efficacy by an oral agent using a CBD. The most effective way by which you can gain benefit from CBD or THC is the inhalant route. 60% of inhaled THC and CBD occurs by 60% of absorption, of THC and CBD occur by the inhaled route, while in the oral route, you're only going to see 15 to 25% absorbed. Inhaled CBD, again, is going to be 40, 55% absorbed inhaled. Oral sublingual is only about 5 to 10% absorbed of CBD. With respect to CBD and whether it converts to THC, there is a conversion that takes place between CBD and THC in the body. It takes place in the small intestine. And so for patients who think that they're getting a CBD product, there may be traces of THC that might emerge from that product by way of the fact that in the small intestine, CBD refers to THC in the small intestine. So you might get small traces of THC in the urine or in your samples product. Moving on with transdermal patches, in vitro testing shows there's 7% absorption, but there's no current in vivo data that suggests that. In other words, we haven't seen it. We've seen it in vitro, but not in the human. So this has been tested in the lab. There's 70% absorbed, but in the human studies, there's no substantial data that supports absorption transdermally for THC or CBD. With use of suppository, again, in vitro testing is 90%, but no current available data that suggests or that illustrates the amount of absorption in the human body by way of suppository use. With respect to inhalant forms of cannabis, the pros are you get a rapid onset, it's inexpensive, there are multiple ways of delivering it. The cons are short acting. There are possible effects of inhaled products that are unknown. We talked a little bit about the carbon dioxide and tar. And also there's a smell associated with use of inhalants. So so you may keep that in mind when you're using these products for your treatment of patients and delivery in the delivery systems that we have. As a result, lung cancer risk. Benzoprine is found in higher levels of cannabinoid smoke, but it does not lead to lung cancer. The reason why it does not lead to lung cancer is because CBD is reparative. CBD helps repair the impact of THC by regenerating the molecules of DNA that help produce lung tissue or help support production or the regeneration of lung tissue. In New Zealand, a 2008 study showed increased risk of lung cancer among higher users and those who are greater than 5 years of age. Maybe not, we're not sure about that. In 2013, heavy use showed increased risk, but overall might elevate the risk of lung cancer, but it's not proven. In a meta-analysis of 5,000 in 2015, and 2,100 cases of cancer cases, 2,900 controls, there are only 6 cases that are known in the United States. There's very little evidence that increased risk of lung cancer occurs among cannabis smokers. Ingestion. There's a slower onset of action. We talked a little bit about what happens with ingestion. Again, it's more potent. There's more potential for psychotropic effects because of this delta-9 conversion to a delta-11 in the liver. And it does easily cross the blood-brain barrier, and as a result, the intensity of the euphoria and the psychosis or the high, quote unquote, is accentuated as a result. Another study with respect to the morphological brain changes and early use of cannabis. First of all, the nervous system really doesn't mature until around the age of 25. So daily cannabis exposure in the age before 17 and for more than 5 years, patients have seen, the studies are showing smaller brain size, but in the percentage of cortical gray matter, but there's no significant impact of the small brain size and the cortical gray matter on IQ. So even though there's a smaller brain size, it doesn't necessarily impact the person's IQ level. However, it does cause or seem to cause smaller stature and also decrease average weight and preemies. And in those who smoke and those who are pregnant and smoke, might see smaller stature birth weights and smaller stature individuals in general in the growth pattern as children. So the other slides are just illustrations of in the adolescent population, is cannabis effective in helping psychosis? Yes, because of CBD. Is it effective in autism spectrum disorder? Yes, because of CBD. So when we understand the use of cannabis and all the aspects by which cannabis can be utilized, what do we do and how do we get this information disseminated? First, we need to learn, we educate ourselves about the process. We educate ourselves about the endocannabinoid system. We discuss patient safety. It's imperative. That's why I illustrated studies that show that overall cannabis is relatively safe. And we also want to make sure that the patient has the right to choose the type of product if they're educated. So I spend a lot of time in my staff, or my staff and I spend a lot of time educating my patients about the different types of cannabis. I spend a lot of time about what's incorporated in cannabis, CBD, THC, and we also talk about aspects of cannabis called terpenes, which I haven't discussed at this time, but I will momentarily. The types of marijuana, dosing, and recommendations. The Entourage Effect, here we go. With respect to the Entourage Effect, we know that there are 130 plus cannabinoids. We know that they're flavonoids. Now, terpenes is very important. What are terpenes? Terpenes is what gives a plant the color, the smell. It's also seen in different spices and scents. It gives the fruit of the lemons and limes, the color, the smell. Those are all terpenes. If you take a hand of tobacco, you sniff it, you're sniffing terpenes. The color of tobacco is typically generated by terpenes. Terpenes are phytocannabinoids, and that's part of the plant-based aspects of them. There are different types of terpenes, okay? And they are myrcene, and here's the other important point. Terpenes actually have characteristics of both CBD and THC. For example, there's analgesic effects in myrcene. Interestingly enough, myrcene is also blocked by naloxone and yohimbine. In other words, naloxone is typically used to, it's a drug whereby we can help displace opioid receptors. In other words, it helps the patient overcome opioid addiction. Yohimbine is good for patients who have problems with erectile dysfunction or other dysfunction regarding sexuality. Yohimbine, myrcene helps yohimbine activate receptors to help stimulate arousal. Myrcene actually helps reduce the side effects of opioids. Henceforth, when you're using cannabis with opioids, you can use them safely. Eventually, most patients will wean themselves off of opioids while on cannabis, and this is a very important component because cannabis can help displace the specific opioid attachments for other opioids, and as a result of that, it helps actually patients wean off of opioids because they don't really need as much opioid use, and therefore you start to use more cannabis, and as a result, you see the changes like I was saying, as we discussed before, 70 to 60% of my patients come off of opioids with this type of effect. Now, how do terpenes play a role in this? Terpenes actually help to identify or give characteristic to the type of plant. So in other words, and I'm going to go through each terpene just quickly. Myrcene has an analgesic benefit. Linalool has a possible stress reduction used for anxiety. Limonene has an adenosine agonist. In other words, this helps with pain, helps with reduction. Carotene it helps to stimulate CB2 receptors. It's anti-inflammatory, and it's also good for helping weight reduction as a dietary supplement. Humulene is anti-inflammatory. It has similar effects to steroids. And so as an anti-inflammatory, you have steroids that we use often, FDA approved. We still have those same properties in the cannabis plant that are assist with FDA managed pain or FDA managed group anti-inflammatory medications. We have that inherently in the plant. The Entourage Effect is the effect of cannabis, the cannabinoids, terpenes, and all things that are in that plant. They work together to give rise to the outcomes that we get and receive from a medical standpoint that's effective. So again, back to terpenes. What's the importance of terpenes? Terpenes actually help to determine and give characteristic to the type of the species of the plant. So in other words, there are different species: sativa, indica, hybrid, and there are two types of hybrid. Hybrid with a predominance for sativa, and there's hybrid with a predominance for indica. Sativa helps attention concentration, is also relaxing as well. Indica seems to promote more calming, more relaxation, is good for sleep aids, good for anxiety. A hybrid with sativa may mean that the patient may have a little bit more propensity for less drowsiness with a hybrid with a sativa component, and with a hybrid with the indica component, it's going to be more calming and relaxing. Now, having said that, what do I mean by why do terpenes pretty much give the characteristic of the sativa plant? When you go into a dispensary, I often ask for the terpene profile. Why? Because the terpene is going to tell you exactly how that specific species of plant is going to operate. For example, if there's a myrcene profile and the species is sativa, that means that sativa plant is going to have the following profile. It's going to have analgesic benefits. It's going to have relaxation benefits. It may also help with blood flow to certain areas. It may be anti-inflammatory. Same thing for linalool. Linalool was a sativa, or linalool was an indica. Indica may be more calming, but it may also help reduce stress, and it may also help reduce pain. It may also help reduce inflammation. It may also help, again, with inflammation, and as a result, the terpenes actually identifies Again, the type of plant and the characteristics of that plant. How does this befit us clinically? If we know that this patient has anxiety disorder, we know that if we offer a patient linalool or limonene, it's going to help with stress and reduction. Whether it's a sativa, if you want to keep the patient alert during the day, or if you want them to sleep at night better after they've had a long day, or if they've had a seizure disorder and they're having problems overcoming the post-ictal phase of the seizure. In other words, there's depression, there's a degree of emotional lability. The type of terpene may help the physician identify the type of cannabis that's going to be necessary to treat that specific condition. That's why when you go into dispensaries, the important point is you want to know about the profile, CBD, THC, and what are the terpene profiles. That's very important. It is inherent upon physicians to understand the terpene profiles help predict and help you regulate your treatment strategy more effectively. Another case study, if I give 4 different patients the same type of cannabis, everybody's inhaling, and I say, okay, contestant number 1, did you experience a high or some type of other experience? He said, yeah, I feel a high. Contestant number 2, I felt a little more anxious with this. Contestant number 3, what did you feel? I felt relaxed and calming. It's contestant number 4, what did you feel? Nothing. Well, that tells you right there that with the same plant, you're getting 4 different outcomes. That might mean inherent in our bodies, even though we have an endogenous endocannabinoid system, it might also mean that individually we have our own profiles for how we're absorbing specific components of the cannabis in our bodies. That means that there's further study necessary to determine, number 1, do we really have a terpene profile for humans if we're responding this way? We know that there's a terpene profile for cannabis. We know that cannabis operates within our bodies with an endogenous endocannabinoid system. That must mean that we as individuals may have similar findings to how our bodies metabolize cannabis. And as a result, that might mean we also are able to metabolize terpenes in the same way as we do. But the only way we're going to illustrate that is doing more in vivo studies, not in vitro, in vivo human studies to elucidate this. We already know right now that we can extract from our urine THC. We do this all the time when we're doing opioid and drug testing for THC. We also do it when we're looking for other metabolites when they're on opioid management. But we can't extract to the fullest extent CBD, nor can we extract in any way, shape, or form right now the terpenes that might be metabolized that are produced in our urines. First of all, we have to create data to find this out. We haven't quite gotten to that point yet. Secondly, what's the other implication behind this? Number 1, if by way of design, we already have testing for alcoholism, in other words, you're driving down the street, you get stopped, you get a breathalyzer. Well, we know that at a certain level of alcohol, that means that there's a certain amount of impairment. Can we say this for THC or cannabis? Not really. We know that with alcohol, everybody's going to have a certain level. They're all going to get some type or feel some type of way with it. We know that there's going to be cognitive impairment. Interesting. With cannabis, we treat disorders with cannabis for what? Cognitive impairments. So can you really say that this person is cognitively impaired by cannabis, or is that a medicinal component of it? So in other words, there's a huge difference between some synonyms. I'm going to give an example. Hi, my name is Dr. Ward. The hi in that instance is going to be totally different than saying Dr. Ward is high. So we have to take this type of scope when we're looking at cannabis and when we're legislating cannabis. What are we really looking at? We're looking at a twofold delivery system. We're looking at a multifold delivery system for a number of different implications for which cannabis can provide. And I kind of get off on that tangent, but I think it's important. But nonetheless, again, whole flower, we have whole flower vaping systems, and these are just the different types of delivery systems that I discussed. And again, We talked about terpene profiles. We're going to say goodbye to the species indica, sativa, and say hello to terpene profiles for the reason I just stated. Again, this is just an example of looking at different terpene profiles. For example, this has high carophyllene. This also has some other terpenes in them. And I'm just illustrating the point that the terpene profiles are very important when you're looking at delivery systems and when you're looking at how we treat patients with cannabis in this regard. Again, dosing. The goal is to start with the lowest dose of THC, and I kind of start low and gradually go up. And this is just an illustration of that. I may start at 2.5 milligrams, and then vaping, I usually go like 1 second vape, sometimes 2-3 times a day. I may also add a tincture to help with sleep at night. And but there are no significant guidelines for dosing for CBD. We know that the average dose for cannabis use is about 1 to 3 grams a day. 5% of it is used. And this is a study done by Ware et al., where really only the average dose is about, you're going to use, if you're going to dose cannabis, you only use about 5% of it in general. So my 3 rules for CBD use, since we don't really know about dosing. Number 1, let's talk about CBD for a minute. CBD must be extracted from a marijuana plant only from dispensaries. All right. The preferred route of administration is vaping. You can use, and it's 8 times more effective for CBD, and about 8 to 4 times more effective when you're using THC. The frequency, the minimum of about 3 times a day for about 2 to 4 weeks is needed for long-term benefits. And I think for any cannabis product that's delivered now, it's going to take about 4 weeks before you know any impact. So I have patients call me in my office in about a month or so after starting my cannabis products, and we review from there. Number 2, when you go into a dispensary, I kind of laugh about this because I kind of joke with my patients. I usually tell them, I say, look, make sure you take with you a stool softener. You make sure you give that stool softener to the person in the dispensary, because you want to know what's coming out their mouth is what you need to hear. So the point is, be careful when you go into a dispensary. This type of education will help you to ask the right questions in the dispensary. Ask for the terpene profile once you learn what those are. Ask about what's in it, where's it coming from? Is it coming from a hemp plant? Is it coming from a marijuana plant? Who authorizes use? Where's it manufactured? What are the products in them? So be hyper vigilant when you go into dispensaries in this day and age. The key to treating the patients is understanding the pathophysiology of the disease. What's the main disease process? For me, is it inflammatory? I might go with something that's anti-inflammatory. I know I'll use a CBD. I know I'll use something to help them with sleep. I know I'll use a terpene that's neuroprotective. I know that I'll use a terpene, or I have a terpene profile that will help with inflammation. And so these are the types of things when I see a patient from a medical standpoint and how I assess what it is that they might need for cannabis. This is how we do it. What's your diagnosis? What is the main disease process? Whether it's psychiatric, if it's chronic pain, is it trauma? And because this might help me determine what type of class of cannabis to use and to what extent can I use it and how. It's important to know, is this person a daily smoker? Are you a once in a while smoker? You tried it a few times, you're back in the day smoker, or have you ever used it at all? Very important as to how I dose patients. The goals are to be legal, to relieve symptoms, get off of pharmaceuticals, get relief without exploring the quote unquote high. And most of the medical cannabis won't give you that type of euphoria that was typically seen in the recreational arena. And these are the different diseases for which cannabis can be used for treatment. And that's a huge list, and I won't go down the list, but look at the list. Lots of disease processes that are treated by cannabis. I'm seeing in my office, anxiety. I'm seeing patients with degenerative spine disease. I just got a referral for a patient with ulcerative colitis. I see patients who have had pain. I see patients who are 6 years old with ADHD. I see 97-year-old patients with Alzheimer's dementia, Pick's dementia, neuromuscular disorders, peripheral neuropathies associated with diabetes, fibromyalgia, irritable bowel syndrome, lupus, Lyme disease, sickle cell disease, bipolar illness, trigeminal neuralgia. I see a wider range of patients who can be effectively treated with cannabis, understanding the profiles and understanding the endocannabinoid system and all the derivatives and all the entourage effect of the cannabis plant that exists. In my opinion, cannabis has been shown to benefit every organ and physiological system in the mammalian body when properly used. Therefore, I believe that it should be instituted as an essential component of every individual's health and wellness. It is truly nature's multi-medicine miracle. Putting into practice. Again, when starting out, any patient that I start again, side effects from cannabis or THC might be tachycardia. It might be tachycardia, headaches, nausea, a blurred vision, numbness around the mouth, hand cramping, chest pain, abdominal cramping. If that's the case, it's going to be typically caused by THC. What do? I add more CBD or reduce the THC. Start off with a high CBD ratio during the day. I typically give THC at night to help with sleep, or I may give THC during the day if it depends on the type. If it's a sativa, I can use it safely during the day. If it's an indica, probably not so because indica causes sedation, so I might use it at night. The importance of the terpene profile. If the patient has an inflammatory process, I might use carotene, or I might use myrcene, I might use some of the others. If the patient has a bronchopulmonary disease, I might use a terpene called pinene, alpha-pinene, which is a useful bronchodilator. My point is this: in this plant, we see a wide array of participation and a number of medical conditions as possible. It is inherent upon physicians to learn how to dose. Do not recommend do not depend upon a dispensary to teach you how to practice your medicine. That is my call for physicians coming together with this. My call to the medical community: learn about what we're doing from the scientific standpoint, because this can help legislate. It can help promulgate laws. Ask the questions. Are we looking at addiction? Are we looking at impairment? How does that impact us when we're talking about CBD? I'm in a lecture. Can I call you back? Okay. Okay, we have to sit them out. Thank you. I'm sorry, I just had an emergent call. But anyway, the point is this. We have to learn how to diagnose, first of all, and use the science of cannabis to help us treat patients. To my colleagues, the Dr. Knox's times 3 and 4, they're a high-power group. They're involved in the endocannabinoid system, but as endocrinologists, it is inherent upon us to learn about how to treat. We understand it's inherent to learn how we use this in the body, as I've illustrated, and it's important to put it into our practice. All right, I don't need to do that. I was going to give an illustration of an example of what that looks like. For example, we have a patient, it's just pulling it all together. 40-year-old patient, a post-traumatic stress disorder with some remote cannabis experience, no desire to get high, night terrors, anxiety, insomnia. And then the second patient is an 85-year-old patient with multiple disc herniations, hardware problems, chronic opioid use. He's got typical chronic pain. The third is a patient, 26 years of age, undiagnosed with anxiety, no medications, cannabis use for the last 10 years. And then we have a 7-year-old autistic child, was non-aggressive or non-communicative and aggressive. What do we do? All of these diagnoses in Louisiana are qualifying conditions. All of these diagnoses can have PTSD, chronic pain, anxiety, and autism are all qualifying conditions in Louisiana. What would I do in the case of patient number 1? A patient with PTSD with some remote cannabis experience, no desire to get high, night terrors, tremor, anxiety, insomnia. I would recommend vaping CBD throughout the day as often as needed, a trial of indica before bedtime help with sleep, Might increase to 2 milligrams at night until they get relief. Now, all these other figures, Granddaddy Purple, Northern Lights, 9-pound hammer, Relax PM, The Dream, The Dreamer. These are all different types of blends of cannabis that can also be used effectively, despite their names, which are a little more grandiose than I would normally expect. But nonetheless, they can work effectively if you understand, again, the profiles in each one of these might be different. And so you want to understand the profiles. So in this particular patient, understanding the profiles, I would pick one of these because the profiles of the product would be befitting for treating the specific diagnosis. In a nutshell. Part 2, an 85-year-old patient with multiple disc herniations, chronic pain, opioid use, no desire for smoking or being high, constant pain. Again, CBD is is my go-to. If the patient does not want to experience high, I'll use an oral indica at night before bedtime because, again, it won't have the psychoactive effects. If you have a 5-to-1 ratio of CBD to THC, there will be minimal or no psychoactive effects. Henceforth, the patient will not experience the quote-unquote high. Next, the third patient, and I'm just moving quickly. 26-year-old diagnosed with anxiety, no medications, hadn't used medications, been on cannabis for 10 years. As a physician, you can diagnose and you can actually make the diagnosis in your office. However, what would I recommend for this 26-year-old undiagnosed anxiety? Come to your office, you say, hey, you're anxious. What would I do? I would recommend vape CBD through the day, needed for the anxiety. If the anxiety is uncontrolled, then I would go to a 1-to-1 indica CBD combination, all right? And vape the indica because it's calming, it's relaxing when appropriate. Now, would I use sativa? If they're an attorney, probably so, because you don't want to vape to the point where they're completely somnolent. So a sativa adjunct might be beneficial in this case if there's a profile, if there's a professional profile. If you're an attorney, if you're a physician, you might not want that kind of sedation, okay? Or if you're a security guard, you might not want to be that kind of sedated, but at night, that would probably be my recommendation for those individuals. Finally, in an autistic 7-year-old child, non-communicative and aggressive, I would recommend a close follow of oral CBD, 5 milligrams 3 times a day. I would increase to 10 milligrams 3 times a day if the symptoms of the aggression are not controlled. Because here we're trying to control what happens in aggression and the emotionality of it in certain parts of the brain, the amygdala, the limbic system. CBD has impact there because we know that CB1 receptors and CBD help in those arenas in that part of the central nervous system. Again, 1 month after CBD use, I'll reconsider adding 2 milligrams of indica, again, for calming and relaxation at night. And so the point is, ladies and gentlemen, and thank you, by the way, is understand these products. Know what they are, know the profiles, adopt the profiles to the specific disease manifestation, and wish your patient well. And I appreciate your time and efforts this afternoon. I'm Dr. Ward. My group is Louisiana Medical Cannabis Institute. I can be reached at gward32004@yahoo.com if you have any concerns or questions. And I'll entertain questions at this time if they are still available. Thank you.
Dr. Ward, we do have a question. Have you seen patients who have or had been addicted to cocaine reduce or stop their usage of cocaine after consuming medical marijuana, CBD, and other cannabinoids? Question mark.
Here's the deal with cocaine use. Cocaine is very, very interesting because the wantonness for cocaine, we use other medicines like Prozac, we use antidepressants in that regard. We use the same concept with the use of CBD because we want to calm the anxiety. We want to create a sense of calm and heightened, at least, and reduce the heightened awareness. And also with cocaine, there's a high level of adrenaline, of excitatory excitation going on in the nervous system, but in a nutshell. So yes, the calming effects will help reduce the wantonness or the need, but it takes time and it takes repeated efforts with this. Unfortunately, we don't in some of our systems by which we're using methadone for treatment and management. I think there's a call for use of other cannabinoids and using for patients who have addiction problems in general. There is a call for that. CBD is that call. CBD as derivatives can help us the outcome and give rise to that type of outcome where we can actually, in this particular case, the answer is yes, but it takes time. But we use a lot of CBD derivatives in order to reach that outcome.
Okay, thank you, Dr. Ward. I think our time is exhausted. I appreciate you.
Yeah, I'm sure.